I don't know why this has been kept in medicine, even though actually gastric carcinoma is a very important in the sense that in the past this was one of the most important and the carcinoma which had most mortality and prevalence or incidence in the world. But now this has been, the scenario has changed and the lung carcinoma has become a first carcinoma. Today we'll talk about this gastric carcinoma, and this is now the fourth most common cancer in the worldwide, and it's the second most common cause of cancer-related death in the world. In US, it's the 14th most common cancer, but these are most common in the Eastern and Northern Asia, China, Japan, India, and Eastern Europe. Part of the South America are more involved in this. The incidence of this gastric carcinoma are very common in this part of the world. And we'll talk about epidemiology later on. And the incidence actually in the world, there are a few factors that have been pointed out why the incidence is decreasing in the world. If you look at the male-female ratio, it's 2:1, and peak incidence is
So go audio mute boy Fedi.
okay. You can hear now.
Start.
So it's difficult to cure in Western countries because they don't have a provision of screening this gastric carcinoma in Western countries, unlike those in Eastern countries, like in Japan, Korea. They screen for gastric carcinoma, so they can pick up the gastric carcinoma earlier, and they have got good prognosis with the treatment. But in Western countries, they don't have this screening system in Western countries, so they're present in a very advanced stage, and thus they have got difficulty in curing gastric carcinoma in Western countries. The decrease in gastric carcinoma is mainly because the use of refrigeration. Actually, in the past, they used to use a lot of salt and salt water to preserve food. Now, because of the presence of these refrigerators, this use of this salt has decreased. So they think that because of the use of refrigeration, there is a decrease in gastric carcinoma with increased consumption of fresh fruits and vegetables, decrease in salt intake, and with the decrease in rate of H. pylori infection, because they are now considered to be one of the cause of gastric carcinoma. So by treating this H. pylori infection, they think that the gastric carcinoma has decreased in the world. And because of the increasing screening in some countries, I told you just in last slide that in Japan, Korea, and other like Chile, they screen the patient and they treat they pick up the earlier lesions and treat it early. So because of that one also, they have got decreased gastric carcinoma. If you go through the anatomy, I won't go through these parts and layers. I think you know how these. But what I want to emphasize is that there are mainly three oncogenic pathways, and these consist of more than 70% of the cases. These three oncogenic pathways are usually involved. One is proliferation, and with the stem cell, kappa B, and WNT beta catenin. But you don't have to remember these things, but these are the ones that usually are preceding for the breast carcinoma. When we talk about the blood supply and venous drainage and lymphatic drainage are very important, because these are the modes by which the gastric carcinoma metastasizes to other places. So we should be very, especially those who are planning to become a surgeon, should have a very good knowledge on this anatomy, this blood supply, venous drainage, and lymphatic drainages. And these are the very common questions that would also you'd get in the exam also regarding these blood supply and lymphatic drainages. So these are quite important aspects in gastric carcinoma. If you look at the risk factors, then basically H. pylori, smoking, alcohol, and diabetes, the use of fats and smoked and heavily salted foods. In genetic components, as first-degree relatives are more prone to have this gastric carcinoma, and there are few environmental components and socioeconomic groups. And the other risk factors are gastric atrophic gastritis, or surgery for gastric ulcer like Gilbert 2 gastrectomy or gastrinostomy. And we don't know why the blood group A is a risk factor for gastric carcinoma. So there are few risk factors, and most of them are usually avoidable ones, like you can treat Helicobacter pylori, you can stop smoking and drink alcohol, you can change these dietary factors. So there are many modifiable risk factors in the occurrence of this gastric carcinoma. If you look at the epidemiology in 2018, these blue ones are the ones which have got a very large number of cases with gastric carcinoma. And if you look at the incidence rate, Korea tops the list with Mongolia, Japan, China. Nepal has got around 4.8 of incidence rate. US has 3.4. United States, UK has 2.8, and India 3.9. So these are the ones they mainly have more cases of gastric carcinoma, like Korea, Mongolia, Japan, China, and Chile in South America. They have got a very large number of cases with gastric carcinoma. And if you look at this thing that we have told about men having twice the increased chances of having gastric carcinoma, there are differences in ethnic group in the same region also. And the interesting point is that there's a difference in incidences and mortality when we move from northern part of the country to the southern part of the country, in northern hemisphere actually. So if you look at in Japan, they have got more cases in the northern part of the Japan than the southern part. In China also, you find that more patients are in northeast or eastern part of the China rather than in the southern part. But in the southern hemisphere, it's just opposite. And if you look at it, the cancer incidences in males in the developed and non-developed countries, then stomach cancer is in the second one, and it's more in the lesser developed countries. This is true in females also. If you look at it, in the fifth most common, but when you compare with more developed and less developed countries, it's more common in the lesser developed countries. So socioeconomic condition definitely has some say in incidences of gastric carcinoma. In the screening modalities, generally they go for endoscopy and sometimes the contrast radiography also, where they can go for this double contrast radiograph or digital radiography. And there are a few blood tests as well, serum pepsinogen or so usually take one or two combined tests in the blood so as to increase the percentage of chances of picking up the patient with gastric carcinoma. Usually they are found in antrum and 20 to 30% in the body, in the greater curvature, and another 20% in the cardia. In the Western population, proximal gastric tumors are becoming more common, maybe because of decreased incidence of S. pylori, because in S. pylori, usually we'll have more gastric carcinoma in the cardia, in the antrum. So the decrease in incidences become more in the gastric body or cardia. Gastric carcinoma, it's more or less always adenocarcinoma, but a few other carcinomas like lymphomas, which is also called myeloma, and leiomyosarcomas, carcinoids, or adenoacanthomas or squamous cell carcinomas, very less in number. But whenever we talk about gastric carcinoma, we generally think that it's an adenocarcinoma histologically. But we should always remember that there are other forms of carcinomas as well. Usually, when you look at the adenocarcinoma, it's usually focal, either polypoidal or ulcerative, and 2/3 of them are in the antrum, and usually the ulcerative, it's intestinal type. We said this one as the intestinal type. It may be diffuse infiltrate, which is also called limitius plastica, superficially spreading. It is diffuse lesion, more prevalent in younger patients. Poor prognosis. Usually spreads primarily to the local nodes, then liver and peritoneum, and systemic spread is a little bit uncommon. In lymphoma, this is also called myeloma. It's a low-grade tumor of mucus-associated lymphoid tissues, so it's also called myeloma, and usually is of large B-cell lymphoma. And if you look at the signs and symptoms, all the gastric carcinoma usually do not have it. So that is why we miss it. Whenever we diagnose gastric carcinoma, it is usually always a late event. So some patients with incidental complaints are diagnosed with the gastric carcinoma, but this can be increased, or the picking up rate may be increased if you go for screening modality. And most of the symptoms of gastric carcinoma would reflect the advanced diseases. So usually, and the disadvantage of this one is that whenever we diagnose gastric carcinoma, it's usually late, and the disease is almost so advanced that it cannot be cured. So we just want to ensure carcinoma be diagnosed earlier, and that will definitely help by screening. Look at the signs and symptoms. It's very vague. Most of them are very vague. Indigestion, nausea, vomiting, may have dysphagia or postprandial fullness. This may be because of partial obstruction, loss of appetite, weight loss. There may be stomach with substance loss, and sometimes there may be periumbilical metastasis, which we call as the Sister Mary Joseph nodule, and it can it can metastasize to ovaries. Where we call that carcinoma. There may be some enlarged lymph nodes like left supraclavicular, which is called varicose nodes, and we call that one as a Troyer's sign. It may also metastasize to anterior axilla, where we call that one as an iris node. These are some very fancy names, like there are a few fancy names in the gastric carcinoma, like Sister Mary Joseph, Kuchenbach's tumor, Troyer's sign, or varicose node, iris node. And there are a few late complications, like the patient may have metastasis to peritoneum and causes ascites, or may have pleural effusion, gastric outlet obstruction, may have jaundice because it may be because of intrahepatic or extrahepatic, and because of starvation or because of cachexia of tumor origin, patient may be very malnutrited. There are a few plastic syndromes also, which are like dermatomyositis, acanthosis, nigricans, and succinate erythemas. Other associated features are peripheral thrombophlebitis and microangiopathic hemolytic anemia. So if you look at it, there are a few particular signs which are very particular to gastric carcinomas, but earlier symptoms may be very vague. And if you look at it, weight loss is very common with abdominal pain, nausea, dysphagia, melena, early satiety, and also typing. So these signs or symptoms are very important, and we call these one as a warning sign. So weight loss, especially anemia, vomiting, dysphagia, palpable abdominal mass, hematomesis of melena, and you should be very careful, and patient should be properly investigated and look for gastric carcinoma. I've told you about paraneoplasty, Troyer's sign, acanthosis nigricans, and peripheral neuropathy. This is Sister Mary Joseph nodule, which is actually a metastasis umbilical area. Varicose node, this is the varicose node, and this is very typical and for gastric carcinoma, and sometimes this is also available in just carcinoembryonic antigen may be increased in around half of the patient, and CA19 may be increased in 20%, but most important is biopsy, which is usually taken with the help of endoscopy. Upper GI endoscopy, and in the imaging, it's in upper GI endoscopy, or we may go for barium swallow. We do chest radiographs or CT, MRI, the abdomen, chest, and pelvis to look for metastasis as well. And there's a new thing called endoscopic ultrasound, which is now available in Nepal also, and it's a very good modality of investigation, and because if you do an endoscopy, just only endoscopy, you'll see only the mucosal layer, and if you have any lesion in that, then it will be picked up. But in endoscopic ultrasound, you can go beyond mucosal layer, and you can see even submucosa, muscularis mucosae, and pick up the lesion if they are in a very early stage. So endoscopic ultrasound is quite an advancement in the gastroenterology, and it has helped a lot in in diagnosing these early lesions of gastric carcinoma. So this is a barium shallow. It's a very traditional one, and you can see the filling defects over here, and this would suspect that patient may have the gastric carcinoma. And in the CT scan with the contrast, you can see the filling defect. This is the endoscopic ultrasound, which is in short is also called EUS, and you can this is the lumen, and this is the one that goes beyond this. So this is the deep mucosa, okay? And so even the patients you can scan it up to serosa also. So this is the advantage of doing endoscopic ultrasound. And if you have a lesion somewhere here, then it can be picked up. But this cannot be picked up with normal endoscopy. These are the one like lesion over here. It can be picked up with endoscopic ultrasound. So whenever we come for carcinomas, we have a TNM classification, and it is generally used to stage the carcinoma. So the T for the size of the tumors, N for the lymph nodes, and M for metastasis. And with the help of combination of these, we can stage it into 0, 1, 2, 2A, 2B also nowadays, and 3A, 3B, and 4. So these stagings are done, and with this help of staging, you can prognosticate a patient and give a survival rate. So if you look at this graph, so see, the overall survival of gastric carcinoma would depend upon the staging of the gastric carcinoma. Like if the patient has got stage A1, then it has got a very good prognosis. But 3C, see, I'd say that has got only less than 20% of survival rate in 1800 days. So as the stage advances, the prognosis is poor. So the importance of diagnosing gastric carcinoma earlier is represented by this graph. This is the same thing, but in tabular form. 1 year, 3 year, 5 year survivals. Like 1 year has got very good survival, but 3C has got very poor survival. So prognostic factors are whether they can be resectable, whether there are presence of or absence of regional lymph nodes. Lineticus plastica has a very poor prognosis, and whenever you do surgery, they send the margins to look for presence of cancers. If that is present, then it definitely would say that they have got very poor prognosis. And if the number of lymph nodes are involved, then the patient has got local as well as systemic failure after surgery and has got poor prognosis. So lymph node involvement, depth of the tumor invasion, and tumor grades are the important prognosticating indicators. Spread slowly, it's very important, and that is why you have to know lymphatics and blood supply of stomach. So from the lymphatics, hematogenous or direct invasion like transperitoneal. So you'd have mainly these three modes of spread, and lymphatic spread is because of permeation or emboli, and I told you about the left supraclavicular node, and that is Stroiser's sign, and nodal involvement does not imply that it has got systemic dissemination. So you should be very, you should note this one, because If you find that there's a node, don't say that patient has got systemic dissemination. In the Barrett's squid, it can go from muscular with this and salsa and as organ like pancreas, colon, or liver. In the blood man, it goes from liver to liver, then other organ including lungs and bones, and it's uncommon in the absence of nodal disease. You can use, so there are mainly three modes of spread. One is lymphatics, where it's because of permeation and emboli, direct spread, and blood-borne spread. So surgery is the mainstay of treatment. Generally go for total gastrectomy, esophageal gastrectomy, or subtotal gastrectomy, or with the lymph node dissection. And the aim of them is R0 resection. That is, there should not be any residual with adequate lymphadenectomy, and there should be negative margin of at least 5 centimeter is required, and in diffuse VS variety, it should be beyond 5 centimeter. And generally, usually surgeons do frozen section. This is what is like while you are operating, they send the margin for the confirmation during operation. They do frozen section and see whether there is a evidence of tumor in that cut margin. If there is, then they go upwards again. So this is how they try to reach the margin with a negative for tumors. In the chemotherapy, it is usually platinum-based combination therapy, and generally cisplatin or 5-fluorouracils are usually given. But nowadays, they have got very good agent like oxaliplatin, and but few novel treatment like biological agents are even used nowadays for treatment of this gastric carcinoma, especially bevacizumab and trastuzumab. And they have they go for sometimes intraoperative radiotherapy, adjuvant chemotherapy. They give do a surgery, then go for chemotherapy, and then surgery, then radiotherapy, or surgery, then chemotherapy. So a lot of modalities for treatment, and usually, if it is possible, then they'll go for radical treatment, but if not, then they'll leave it as a palliative procedure. So they'll go for wide local real excision or partial gastrectomy, or they go for gastrointestinal anastomosis or a bypass. Sometimes even they do a jejunal. They bring out the jejunum into the skin and put it as a feeding jejunostomy. So it depends upon what is the extent of the disease and how much radically they can treat. It depends upon the patient's staging of the gastric carcinoma. So I think this is what we have got. But I didn't go into detail about the surgery. I think it will be dealt in surgical classes later on. They have got few